I'd like to invite Dr. Ravikar to moderate the session on using participatory approaches for health equity from research and advocacy to clinic by Dr. Harikeerthan.
Good morning. The next speaker for today is Dr. Harikeerthan Raghuram. Dr. Harikeerthan completed his MBBS from CMC Vellore and then did an MSc in Health and International Development from the London School of Economics and Political Science. His areas of interest include health policy and health research, and he has been working towards health equity and social justice in India through research and advocacy. He is currently a senior project coordinator at Sangat, a not-for-profit organization based out of Bhopal, where he initiated and co-founded the Initiative for Health, Equity, Advocacy and Research, and has been coordinating multiple projects working with marginalized communities. He's also pursuing an NIMH-funded Essence Fellowship in Implementation Research in Global Mental Health in South Asia. And he will today be speaking to us on using participatory approaches for health equity from research and advocacy to the clinic. Dr. Harikeerthan.
Thank you so much, Dr. Ravikar. I'm very glad to be speaking in this hall because my mother studied in the same building probably around 45 years back. And I studied in this campus. Glad to be here speaking publicly almost, I think, after 10 years. So I graduated from CMC, as Ravikar said. I worked for a couple of years, was not very happy with clinical work. I thought to make long-term change, I had to be within the government, tried preparing for civil service exams, didn't get in, worked with the NHM in Tamil Nadu, had a great experience. Then went to LSC, did my master's. And then I came back. I joined Sangat because I was very much interested in mental health. And at that time, my boss, Anant Pan, he asked that there's a funding call. Is there something you're interested to work on? Can we apply for it together? So I said, yeah, I just finished my dissertation with the transgender community looking at gender transition. A lot of them shared that they have been having challenges in accessing healthcare, especially during the COVID-19 pandemic. And I had been working with learning about the trans community, especially through the NHM period at LSE. So he said, okay, sure, let's speak to Dr. Aksa, who's a trans woman and a professor in Delhi. And so we together prepared a really nice proposal, very simple, qualitative work, theoretical approach methods, everything matching together, good team. But it didn't get funded. Then we applied to a second funder. Again, it didn't get funded. But this time, the funder gave us some personal feedback. And this feedback has set the course for the work that I hear for the last 3 years. So what basically they said is that even though Aksa was part of the team, otherwise it's largely cisgender, heterosexual men, privileged doctors who are trying to understand what are the health challenges of trans community, diverse people from the trans community. Why should it be you? Why not somebody? Why not a group of trans people? And it didn't get funded. So I was quite disappointed. And this is the second time. And thinking this is an expert team, why can't we do this? And of course, maybe in the future that can happen. So then we went back to the drawing board, read up a lot, talked to some people, and understood that understood about participatory approaches. And what participatory approach is basically a collaborative approach where there is equitable involvement of communities in all aspects of the research process. Because otherwise, it's a bunch of people from outside of different communities, typically from academic institutions, who get to decide what research is done, what method is used, how it is went about, which is the sample. And that means power is yet again taken away from a particular marginalized community. And to bridge that gap is participatory research. So in this presentation, I'd like to speak a bit about how at IHERE we've been using different participatory approaches in research advocacy. And then in the end, I'd like to speak a bit about how it can translate to the clinical space. So in the spirit of developing equitable partnership, we'll be doing different things. First is by building the team itself. And that starts by recruiting people for particular projects from the very communities that we're working with. For example, if it's a project with the trans community, then we try to hire somebody who has the necessary research qualification, but is identifying as a trans or a non-binary person. If it's a project with the disability community, then we look for somebody who's from the disability community. And over the last 3 years, over several projects, now we've built a team of almost 12, 13 people. Most of us are from the queer or disability communities. And also we work with collaborators who also bring their own lived experience as well as disciplinary expertise. The second method that we've been using is advisory boards. And this is a photograph from a project where we're looking at vaccine access among the trans, intersex, and disability communities. So the study is co-led by an advisory board, which has representation from all three communities. And thirdly is to use workshops where we sit with the community, not for data collection, but as a way to sit with them and discuss the research design. So this particular workshop was primarily to finalize the research question in our first project called Transcare COVID-19. Another one, this is from the Vaccine Equity Project, and this is with consent. So we discuss the research question, the interview guide, the sample, and we go back to them. So it is an iterative process. So it happens every 2-3 months with representatives of the community. So this is another method we use to create that equitable partnership between researchers and the community. So basically the question is, as Dr. Yogijin spoke about how many of us as doctors don't necessarily have the lived experience of what we're talking about. We've never been through it ourselves. So therefore is the need to value lived experience and giving back the ownership of the research process to people for whom it matters the most. So as I mentioned, using the participatory approach, we started our first project, the Transcare COVID-19 project. And using the learnings from that project, things we learned through the workshops, one thing we learned was about challenges in vaccine access. And that led to a second project called I Hear Vaccine Equity around November 2021. And Bhakti joined the project as a research assistant, and Bhakti is a person with 100% visual impairment. So I asked Bhakti if she would like to share a bit herself. So she recorded a short video. Let me try playing it.
Hello everyone. My name is Bhakti Ghatole. I'm currently working with Hari in Vaccine Equity, and I'm 100% visually impaired. So talking about participatory research, often it is seen that researchers identify the problems and then they themselves come up with the solutions for the community. And this exact notion is challenged by the participatory research, where they emphasize that the researchers need to identify problems by involving the community and collaboratively design solutions for them. So during vaccine equity study, we were also trying to understand vaccine hesitancy, and often trans and disability communities were blamed that they are not coming on the center and taking the vaccination. So it was assumed that, there is some kind of hesitancy, some kind of fear within these two groups. But when we interacted with them, we found that there were so many different levels of challenges, including informational, transportational, infrastructural, because of which, even if they wanted to, they found it so difficult and challenging to step out of their houses and go and take the vaccination. So it is not possible to unlearn ableism and heteronormativity within one day. And therefore, it is important to have continuous dialogue with the community, especially when we are conducting research, when we are planning interventions for them. So somewhere that became possible when we were doing vaccine equity study. We had community members as collaborators, advisory board members. We could also conduct some workshops with them. And then the research process, not just remained about what to ask, but it became also about how to ask and how much to ask. So I feel that nothing about us without us, it should be the lived experience of all our research participants. And if we want to move towards health equity, then we need to have equity in the process itself. Thank you so much. Hello, everyone.
So in the past few slides, I elaborated on few principles of community-based participatory research about how the partnership needs to be equitable and what processes can be done, used for that, creating spaces for co-learning where both the researchers and the community members are learning from each other, using an iterative process of going back to the community again and again as we continue in the research study. A second limitation of a lot of traditional research, and for example, an interview-based study is, as a research participant, as a community member, a researcher would come to me, let's say it's an interview, and ask a specific set of questions, and I get to only answer those questions. If it's a survey, then it's very much limited. Maybe it's just options I give, or if it has open-ended questions, then it's a little bit more better. If it's a qualitative interview, then there's more control. But a community member who's a participant would never get the chance to decide what is the question that is asked in those particular interviews. And to bridge that gap, there's been a lot of developments in participatory research methods. And in the vaccine equity study, we incorporated one of them, which is photo voice stories, where community members themselves collect data using the medium of photographs. And this is also because, as somebody shared on day one, that we are all knowers, we all know things, but not necessarily have the ability to communicate it in different ways. And photographs gives another media to capture those knowledge that is there in the community. This is a photograph taken by one of our participants, Abha. She's a woman with locomotor disability, and she also gave this narrative that went along with the photograph, which is that if there's a mode of commute, then I'll go to the hospital. If it is not available, then I can't do anything. And this is a photograph of her going to get the COVID-19 vaccination in Delhi. And I also asked if she would like to share a bit, and she's kindly recorded a small audio clip for us.
When I agreed to take part in this project, I was very much excited that I would be able to create some awareness among persons with disabilities, that how can they advocate for themselves for home-based vaccination. So I agreed to take pictures and send pictures for the project. But while taking pictures, I faced certain challenges because I could not go out myself sometimes, and I had to take help from my family members to take the pictures. But yes, the overall experience was great. I could compile different pictures and tell my own story of taking vaccination and the various kinds of hurdles and the success that I got while getting the home-based vaccination. In my district, I was the first one to get home-based vaccination. So the whole project was very interesting, and I loved taking part in it. And I hope more of such projects they do come along. And as a person with disability, I would be able to contribute in awareness generation.
This is Naz, another participant from the Photo Voice Story, who also shared their experience. Naz is a trans non-binary person. Capturing my experience through photographs allowed me to express myself without any limitations. It opened me to my lived experience in a deeper sense. Photo Voice Stories offered a unique lens into the hardships faced by transgender and disabled communities. I believe this method of research allowed for a stronger impact in portraying the lived realities of many. So this method, use of such methods, such participatory method, helps to build on the strengths that are there already in the community. It shifts the power imbalance that is there between typically academia or researchers and the community to make it more equitable. The knowledge that is generated, as Abha mentioned, was she could immediately use it for her own advocacy itself. It was not like a research paper that is inaccessible. And another feature of participatory research that you would see, and a principle, is that often it starts shifting the focus of the research from individuals and behavior to systems and structures that are oppressing them in the first place. And like Abha herself mentioned about her challenge in being able to access home-based vaccination, how the photographs helped her access that. Meanwhile, in 2022, while we were doing this project, another challenge that we were starting to face is that even though now many of us from the research team were from the community, because of the training that we've had, the kind of language that we speak is quite jargon heavy. in research spaces. And this makes it quite inaccessible and creates that power difference with community members who would want to otherwise own the process. So what we felt is that maybe we need to start working towards creating spaces where people from the communities themselves can develop that language and then be more active participants and maybe even do research and advocacy themselves. And towards this, we got funding for another project called I Hear Peers for Equity. And what we did here is through a short digital course and a mentored fellowship, 6-month-long fellowship, people from the LGBTQIA+ and disability communities were trained to be able to do short research and advocacy themselves. And the mentoring was also by people from the queer and disability communities who have been able to do that. So it was a peer-led, peer-conducted program called Peers for Equity. And one of our participants had shared this testimonial. For the longest time, research on trans and neurodivergent people has been done by cisgender and neurotypical people, which had disastrous consequences for us. So with that in mind, I wanted to use this, meaning the fellowship, as the first opportunity to develop a scholarship for us. This is said by Shinjini, a non-binary neurodivergent person from Delhi. Now I come to the second last principle, which is dissemination. And the core aspect of participating research is that we do not stop with dissemination of findings just with academic audiences, with a journal article or a conference presentation, but to go beyond that, especially to give the findings back to the community, to take the findings to create action, for example, with government folks and policymakers. So in the photo voice stories, by November, we finished collecting the photographs. Then, and meanwhile, we've been having these sessions with community members, and we were asking them how they would like to share those photographs. And based on those suggestions, we created different methods of sharing the findings, both from the photo voice stories component as well as the interview part of the component, interview component of the study. So the first one on the left was a web page that we had created where we put up all the photographs along with the narratives. And this also, we made efforts to make it accessible to people with disabilities. So each of them not only had text-based narratives, but also audio description of the photographs so that it's accessible to people who are visually impaired. We held an event in Delhi, and Delhi because so that it's more accessible to policymakers, even though we are based at Bhopal. And some of our participants are also from Delhi. So some of them came and they themselves inaugurated the exhibition, released a booklet with the photographs, and this were given to, and the audience was largely people from different NGOs, INGOs, and government involved in the vaccination program, including the COVID-19 vaccination program. And the second one on the first one on the top is a policy brief. So for policymakers, we created a 2-page policy brief, so it's very easy to read. But for community members, we made a longer lay summary kind of thing where it's much simpler language, both in English and in Hindi, so that the community members are also learning what the findings of the study were and then can use that. And of course, we wanted to reach out to academic audiences, and the two research assistants in our team, Sharon, submitted an abstract to the Global Vaccine and Immunization Research Forum in Incheon, South Korea. So they went to present there. Bhakti and Sharon, both of them presented at the Vaccine Acceptance Research Network conference at Bangkok in Thailand. Now coming to the last principle, which is commitment to sustainability. So over the last few years, we've been working through a series of projects, one building on the other, some which are research focused, a lot of work with medical education, capacity strengthening, inclusive spaces. But how to sustain this work, because we're completely dependent on external funding. And one thing that we understood is to build the team itself, so that tomorrow, each of the people who join the I Hear team themselves become leaders, and then they can continue the work. So now many of us in the team are themselves writing research proposals, getting funding, and starting their own work. But towards that, what is important is that one is, of course, the core mission being building the team, largely from the communities that we work with, who are able to continue this work. But that means it's not just important to hire people, but also to make the workspace inclusive of people from diverse communities, because otherwise the workplace is not inclusive. It's very queerphobic, ableistic. So towards that, we've been doing several things such as making a policy, having sensitization events, changing our workplace policies and rules to make it more flexible for people from marginalized communities. And we are now in the process of developing a disability policy, which Bhakti and Joshua and others are leading in drafting them for persons with disabilities themselves. So this is where we feel is the core of how the work can be sustained. And the idea is that not just people, but creating a space where people with the lived experience can be authentically themselves, work with diverse stakeholders, academics, researchers, advocates, towards working for health equity, and that is the vision that we have. And towards that, Sharon, my colleague, who is a queer non-binary person and a psychology graduate from DU, shared a bit. I would just like to say that we need to think about the ways in which medicine, research, and policy are all systems that are entrenched in and uphold stigma against marginalized communities. Once we acknowledge that history and legacy of harm, transphobia, homophobia, ableism, and casteism, we can begin to envision a more affirmative healthcare. Participatory research and design provides an approach towards reducing this harm, with communities co-leading and co-developing solutions as experts instead of medicalized subjects. While this sounds simple, it is an iterative, time-taking, and mindful investment in a community and requires us to slow down and reflect critically on the paradigms that we work with and make space for new ones. Lastly, always pay marginalized communities for their time, input, review, and consultation. So now coming to the last section of the presentation, which is what about in the clinic? And yesterday, Ritupriya spoke about how as health professionals, we are part of the system. Today, in the earlier presentation also, I'm sorry, I forgot their name, spoke about how we are part of this system which is creating this oppression, which makes us also as oppressors. Building on what Dr. Vinod Shah spoke, I would like to suggest an exercise bringing together John Rawls' theory of justice and Gandhiji's talisman, that we know that healthcare is a source of disparity and inequity. And most of us have been quite privileged to be in this position where we are doctors, nurses, public health professionals, and in control of running the system, making decisions. But what if tomorrow we were born different, or today we were born different and we were born in the most marginalized community that you can think of? Would you be okay with not being in control at all of what research is done on you, or how the healthcare system is run, whether the space, how the space is designed, the kind of doctors you are forced to meet, the kind of experience you're forced to have? Which means that we need to move away from this traditional paternalistic model of medicine where doctors, typically what used to be a white man in a white coat being in charge of everything. We need to move away from that system. Participatory approach stands antithetical to that traditional paternalistic model of medicine. It is also misaligned with the idea of colonial medicine, where the doctor in the white coat knows everything better and is in control. So what can we do in our settings as MD medicine graduates, since this is a medicine conference? First is medical education. Paulo Freire said that there is no such thing as neutral education. Education either functions as an instrument to bring about conformity or freedom. So are you teaching your students to bring about conformity to the status quo, or are you teaching your students to bring about freedom and equity? So different things can be done. Participatory development of curricula. Is it just NMC and the medical education department who designs the curricula? Or are we talking to local communities, marginalized communities, people with lived experience of cancer, for example, as Parth spoke about, in the development of curricula? Are our campuses inclusive of people from the marginalized community so they can be here and speak to other students, speak to us, share their experiences? Do we have faculty? Yesterday we spoke with Rakhal about diversity in faculty. Do we have faculty from the trans community? How many Dalit faculty do we have? And does the content that we have, are they all just content written by medical textbooks and authors, or do they have elements of lived experience? For example, one of the projects that we're doing called Queer Chronicles, we're working with people from the queer community, asking them to bring out their lived experience in the form of artwork, which can eventually be included in medical education. So short videos, short magazines called as zines, and short written articles. Second is the health workforce. And this statistics I found, which is that the Dalit community is grossly underrepresented in health professions, especially among specialists. The Advocacy community even worse than that. So there is definitely, as we discussed yesterday, need for affirmative action that, we can't, this is despite reservations. So yesterday somebody was talking about whether we need reservations in specialist education. Right now it's grossly underrepresented. And if there's a gross underrepresentation of Dalit doctors in, let's say, endocrinology, are we going to be able to provide equitable care to Dalit populations among us for their diabetic needs and endocrinology needs? But it is not just important, not just enough of affirmative action, but our spaces also need to be affirmative. Can tomorrow, if a trans doctor comes to work here, is it going to be a safe space for them? And finally, healthcare planning and implementation. And so yesterday I was having a conversation with somebody about whether CMC or the CMC's different hospitals, whether the communities that they serve have any say in how the hospital is run. For example, let's say, so world over now there is a growing movement where the people who are using the service users or patients are starting to have a say in how the healthcare is planned, designed. And this is in line with our need to rethink who controls healthcare and giving back power to individuals. For example, we can have patients who are involved in evaluating our services, doing audits, advisory boards to advise us on what we should do next as CMC, and also maybe co-owning, like we saw the wonderful example Ajit spoke about in Godalur, service users and communities co-owning the healthcare system. So finally, in summary, I'd like to just give you two key takeaways. One is that we need to move away from the system where you need an MBBS or an MD or a super specialty degree to be an expert. We need to start valuing lived experience expertise. Many of us don't have any clue of how it is to live with cancer, except I don't know if there are people here. And many of us end up giving advice about things we have no lived experience about. And when there is somebody who's lived through years with diabetes, with an amputated leg, can we start valuing that as expertise? And can we have them be included in the healthcare that they receive? Second is that for a long time, we've enjoyed this privilege of being in control of medical education, being in control of health systems, health policies, health financing. I think it's enough. I think it's time we give back control to the people to whom these things matter the most, the service users themselves. Paulo Freire said, to alienate human beings from their own decision-making is to change them into objects. So are we going to continue in the business of making people into objects, or going to start treating people as humans? Thank you very much.
Thank you very much, Hari, for that wonderful talk. And I'd really like to appreciate the fact that you use the same approach that you've been speaking about in your talk as well. And it's so great not only to hear from you, but also to hear from so many other people, from Abha and from Bhakti and so many others. So we've actually heard the voices of so many people through your presentation, which again, I think emphasizes a participatory approach. So you really walked the talk with your presentation, and we will now be open for a few questions. The first question is, what were other groups that were identified as having lower vaccination rates? And were the barriers to vaccination access similar across all groups?
So our study worked only with the trans and disability communities looking at vaccine access. It was primarily a qualitative study, so I cannot comment about what are the other groups who have lower rates. But the kind of challenges, there were a lot of commonalities. For example, the way the healthcare is designed. Our hospitals, vaccination centers are designed in the binary of male and female, starting from the queues to the washrooms to the wards. And it is designed for able-bodied people. There are steps everywhere, and I think including in this building. There may not be lifts, including this building, which makes it an exclusive space for people who are the privilege of being able-bodied. So the way the healthcare system is designed is only for people who are cisgender, heterosexual, male, female, able-bodied people. Second thing is about information, which is that whether it comes to research or dissemination, information is again limited to cisgender, heterosexual, able-bodied, male, female, probably more male, and people. And the way it is disseminated is also often not accessible to people with, for example, disabilities. And a lot more things. I can share our findings.
I just have one other question for you. Can you share what experiences of your own led you to sort of work with the vulnerable communities that you're working with right now? What actually made you personally decide to sort of select these communities amongst many other vulnerable communities and focus on them?
Okay. So my learning experience from the trans community didn't start at CMC. Most medical colleges in India don't talk much about trans communities, actively exclude them. When I was working in NHM, I was working on the mental health policy, and somebody asked me, is the policy inclusive of queer communities? And my answer was, I don't know. And then I was trying to find out what are the needs. And I met with activists, people from the community in Chennai. I was working in Chennai, and it was a steep learning curve because till then I was very much trained into this model of there's only cisgender, heterosexual, male, female. Anything outside of that is either a criminal offense or it's a pathological disorder that needs cure, or is something we should not be talking about at all. So that was a steep learning curve, but that was the initial stage where I met a lot of people from the trans community. So again, at LSE, my dissertation was with the trans community. So that's why it started. But there are several other personal experiences as well, which I think I'll skip for now.
Thank you very much. I think the time is up. And thank you once again for that wonderful talk.
I'd like to ask Dr. Ravikar to present the memo to Hari.